This is Joshua Guetzkow from Israel, and he's here to talk to us today about the effects of the COVID-19 vaccines on pregnant women in Israel. What is it about women who've been injected with the COVID-19 vaccine between the weeks of 8 to 13? Stay tuned to find out. Hello, Joshua. How are you today?
I'm good, thanks. How are you? Thanks for having me on to talk about this new study of ours.
Yeah. So, what made you decide to conduct the study?
There are a few things that brought us to conducting this study. One is that there haven't been a lot of studies of the impact of COVID vaccination in early pregnancy. There's a lot of research done on impacts later in pregnancy. So that was one thing. Another thing was that the way that the studies were being done, even though they weren't finding signals of concern, the fact that they weren't actually finding any differences between the vaccinated and unvaccinated women led us to think that there might be some issues. I could get into all the details of the potential biases that we were sort of picking up in the existing research. One of the problems is that in existing research, they look at women during these vaccination drives and they compare vaccinated women with unvaccinated women. And there's a well-known bias in studies on vaccine efficacy, or I should say effectiveness, where it's called the healthy vaccinee effect. And essentially what it means is that people who tend to be healthier on average, usually not in every instance, but generally speaking, people who are healthier on average have kind of a health conscious, health seeking behaviors are the ones who go out to get vaccinated. And so you would expect better outcomes among those women who went out and got vaccinated compared to the ones that didn't get vaccinated just on that basis. And even if you include all these statistical controls for various comorbidities and other aspects, this healthy vaccinee effect is actually a very difficult thing to measure. So it can bias the results. And we felt that there might be another approach that you could take that would help check that, alleviate that. Another problem is that a lot of these studies didn't have a very long follow-up period after vaccination. Most of the studies only followed the women for a few weeks after they were vaccinated. And one of the unique things about our study is we look at the entire period after a woman's been vaccinated. And we found some really surprising results because of that, because we're looking at this long follow-up period and not just focusing on a few weeks.
It's a good thing you did that. So I see that you've got vaccinated women with COVID-19 who had a stronger result than people who were vaccinated with the flu vaccine.
Yes, absolutely. So let me take you through kind of our results and our methodology. There's a well-known method for examining adverse events following vaccination. The methodology is called observed to expected comparison. So essentially what you do is you say, okay, we're going to look at some adverse event that occurred to people after they were vaccinated, say within a month after vaccination. We're going to count how many of those adverse events occurred to people following vaccination. And we're going to compare that to the number of those adverse events we would have expected in that population in that time period. Okay, so if I see that there are 40 cases of myocarditis 2 weeks following vaccination, and when I was expecting 2 events, not 40 events, then that raises concerns, right? That there's a problem with the vaccine. So this is a well-established method of looking at safety signals for vaccination, and CDC uses it. But the method that the CDC and others use tends to only take into account things like age and sex when they're kind of making these comparisons, right? So you're making a comparison to a background rate, but you're not really adjusting very well for people's characteristics that will make them, so some people are more likely to get myocarditis, for example, or some women are more likely to lose their pregnancy. And so what we did was we used an innovative methodology where we built a statistical model based on historical data from 2016 to 2018, where we are able to predict the likelihood that a woman will lose her pregnancy based on her individual characteristics. If she smokes, what's her age, what her comorbidities are, all those kinds of things. What are her risk factors? Based on the timing, the calendar timing of the pregnancy, based on the week of pregnancy, right? So a woman in week 8 is much more likely to lose a pregnancy than a woman in week 20. And also we know when the woman if women's pregnancies were considered high risk. So all of those things, we take those into account, we build a statistical model, then we use the results of that statistical model and apply them to women, pregnant women in the COVID period. And so we're able to predict based on this historical model, we're able to predict for every woman specifically based on her characteristics, the week of pregnancy, what is the likelihood that she's going to lose her pregnancy at some point over this period. So it's this observed to expected, but it's individualized. And essentially what we do is we look for every week of pregnancy. What's the probability that a woman will lose her pregnancy? So we can say, okay, if she was vaccinated in week 8, we look at all the women vaccinated in week 8, we say, okay, what are the number, how many of these women would be expected to lose their pregnancy on the basis of this historical model? And how does that compare to what we see in reality? And we can do that for every week. And what we see is very concerning. We see that in the first trimester, there's a large increase in the number of observed fetal losses compared to the number that were expected. So if we average over, so we look in the first trimester, we're only looking at weeks 8 to 13. I can explain why if you want, but what we see is for every 100 pregnancies, women vaccinated in those weeks 8 to 13 saw 4 additional fetal losses per 100 pregnancies above what was expected. And in some weeks, it's even more. So we look at dose 2 and we look at dose 3. Here, let me show you a slide, just to kind of give your readers or your viewers a visual how this looks. So we see here when women were vaccinated with dose 1, we expected 9 fetal losses in those weeks 8 to 13. We expected 9 fetal losses per 100 women, and we saw 13 fetal losses per 100 women. Now, we also looked at dose 2 and we find a similar difference. And the reason for that is that most of the women who got dose 1 also went on to get dose 2 during pregnancy. And so it's sort of measuring the same difference twice. So we only show the results here for dose 1. And then for dose 3, right, the booster dose, we see a somewhat similar increase where we have, instead of 10 expected fetal losses, we see 12 observed fetal losses. So these are really big. I mean, if you stop to think about it, 4 additional fetal losses per 100 pregnancies, that's 4 lives lost for every 100 pregnant women who were vaccinated in these weeks. And of course, these differences are statistically significant, as you might expect. And then you mentioned the influenza vaccine. We also compared what happens to women who get vaccinated for influenza during this period. There's something that's really, really important to point out about this finding, right? So we find about 4 additional fetal losses among women with dose 2 in weeks 8 to 13. But then we looked at what happens later in pregnancy. When do those unexpected additional fetal losses occur? And what we found was that more than half of them occurred from week 20 of pregnancy, and almost half of them occurred from week 25. And essentially what that means is that more than half of these additional fetal losses were stillbirths. Right? They weren't miscarriage, they were stillbirths. So what we're seeing is that there's this sort of delayed, don't want to go quite so far as to say it's an effect. If this is an effect, there's some kind of delayed change. So the reason that we started looking at these later fetal losses is because we said to ourselves, well, maybe some of these fetal losses are due to elective abortions, because we look at all fetal losses. We don't differentiate between different types of fetal losses, including elective ones. Now in Israel, elective abortions after week 14 are rare. After 20, they're extremely rare. And after week 25, they're basically not allowed at all. You cannot just volunteer to say, I don't want this baby anymore, I'm going to get rid of it. There have to be very extreme circumstances to allow for that. And so what we can say is that most of our signal, most of this difference that we're finding cannot be explained by elective abortions. It has to be something related to biological mechanisms.
What normally happens on week 25 of a pregnancy in terms of development, approximately? Yeah.
Well, it's not that there's something happening specifically at week 25 that's making this change. It's
Okay.
just that we tried to track what proportion of this additional fetal loss was happening at sort of different time points in pregnancy. And the reason that we chose week 25 is because week 25 is the point where, according to Israeli law and regulations, women just essentially cannot get an elective abortion. So we used week 25 to say there is no possible way that the difference that we're observing from this week, which is almost half, right, is due to elective abortions. So it wasn't specifically related to the biology. Although it is interesting that you bring that up because a lot of the feedback we've gotten is, well, you have to separate out stillbirths and miscarriages because the biological mechanisms of loss are different. The problem is that if you do that, and that's what most researchers have done, is that you break up your signal, you break up the addition, you lose the information. So any difference or any effect that you would find would be smaller and harder to detect. So by the fact that we looked at this longer time period, allowed us to more easily see that there was a big issue.
Thank you.
Now, yeah, sure. A lot of people have argued, and we thought this ourselves when we were doing the research, is that the COVID period is incomparable. You can't use estimates from an earlier period and then apply them to the COVID period, even though the CDC has done similar and other EMA, they do it, but when it shows something bad, they say you can't. But anyway, maybe there's something about the COVID period itself that made this increase, right? It's not about the vaccination. So what we did was we looked at women getting vaccinated for influenza in the same time period. Right? So if it's something related to the COVID period, then we should see it among influenza vaccine. But what we see among influenza vaccinated women is that it's actually the opposite. We see fewer than expected fetal losses among women vaccinated for influenza in those same weeks. So for the COVID vaccinated, we have higher than expected, and for the influenza vaccine, we have lower than expected. A sense of what this looks like, I'm going to show two graphs. The graph on the left shows, okay, so the axis here it shows the week in which the women were vaccinated. Okay, we looked from weeks 8 to week 27. And then we count sort of for all the women vaccinated in week 8 per 100 women, what is the expected number of fetal losses? That's this dotted line. And what was the number actually observed? And that's this solid. And so what you can see is that for these very early weeks, the difference between observed and expected is much larger than 4, right? It's in some cases closer to 9. It's around 9. But if you average over the entire first trimester from weeks 8 to 13, you get 4 additional fetal loss, right? So, but now you go over here to the influenza vaccinated, and you see exactly the opposite. You see a lower than expected fetal loss rate, right, for women vaccinated in these early weeks. So one hypothesis is that, well, it makes sense because women are getting vaccinated for influenza. They're protected from influenza, and that's why they have a lower than expected fetal loss rate. The problem with that, there's a couple of problems. One is that no study has ever found such a large protective effect of influenza. The other problem with that is there basically was no influenza during the COVID period, or at least that's what we were told. That's what they measured, no influenza, especially for one of the 2 years. Now, we validated our results on a different period, 2018 to 2019. So we run our model, and then we applied it to the period 2018 to 2019. When there was a very heavy flu season, and we see almost the same exact results, this lower than expected. So in a period where there's lots of flu and in a period where there's no flu, we see this same difference. And so it's not a protective effect of the influenza vaccine. We believe it's a sign of what I was talking about earlier, the healthy vaccinee effect, right? Where there's women who sort of healthier on average, their pregnancy is going really well, right? If your pregnancy is not going well, you're having spotting, I don't know exactly what, you're vomiting, you're probably less likely to run out and get an influenza vaccine. And so what we're seeing here is it's picking up on a healthy vaccinee effect. And in fact, that's exactly what you would expect for the COVID, or almost exactly. You would expect something similar for the women who went out early and got vaccinated for COVID early, right? We see it for the women, if you look at this graph here, right? So from week 14 on, these women are lower than expected. And it's very similar to the influenza vaccine, right? And so the healthy vaccinee effect seems to be, by the way, we looked at COVID infections. COVID infections we don't find any difference between observed and expected among women who had COVID infections, not in the first trimester, not in the second trimester. So that's not explaining this difference. What explains it is this healthy vaccinee effect. So we see similarly in the COVID period, we see for the second trimester, weeks 14 to 27, a similar lower than expected. So it's a similar kind of healthy vaccinee effect, but we don't see it here. We don't see it for the COVID vaccinated, the women who vaccinated earlier in pregnancy. Strong indication here that there's something amiss. There's a glaring signal here. In addition to that, if these women should look like the influenza women, where they're lower than expected, okay, they should, because of this healthy vaccinee effect, they should be lower than expected. Well, then guess what? It means that actually this 4 additional fetal losses per 100 pregnancies is probably closer to 9 additional fetal losses per 100 pregnancies, which is, that's almost 10% of the women vaccinated during these weeks that would have been losing their fetuses at later stages of pregnancy, right? There are many of them experiencing stillbirths as a result of this.
Well, that's shocking. That's absolutely shocking.
Yeah, yeah, it is. It is. It shocked us. It shocked us. I mean, look, there are people out there throwing around figures like 82%, 81%, 86% miscarriage rates among COVID vaccinated women. Unfortunately, those figures are based on an erroneous understanding of the documents from which they're drawing that conclusion. There's a report from Pfizer. It's basically a collection of adverse event reports. And it isn't 82% of pregnant women who are experiencing miscarriages. Of the adverse event reports that were related to pregnancy, 82% or 81% of them reported a miscarriage. But the number of women that are reporting a pregnancy related adverse event isn't the correct denominator. You don't divide by that. So when you start dividing by that, yeah, you get these huge numbers, but it's just the wrong way to do the calculation. A more correct way would be to say, of all the pregnant women who were vaccinated, what percent experienced miscarriage? And that document can't tell you that. There's another study that was published by the CDC from vSafe data looking at the miscarriage rate, and people are again not understanding that the denominator that they're using is wrong. When they published that report, many of the women hadn't finished their pregnancy, and so they weren't included in the denominator. And so again, they're dividing by the wrong number, and it creates these inflated rates. If it was 86%, 80%, it would be unmissable. It would have caused such an outcry. I mean, it would have been not something that could have been easily hit. What we're finding here is that the number is lower, but it's still shocking, right? The number is lower, but it's still extremely concerning. It's devastating, actually. A couple of reasons why it wasn't sort of blaring in people's faces. I mean, some people were aware of it. There were lots of anecdotal reports, stillbirths, that sort of thing. But essentially, there are 2 reasons. One is, at least in Israel, very few women were vaccinated in those sensitive weeks of pregnancy. And so it didn't affect a large number of women. And also, the increase, the excess, was spread out throughout their pregnancy. So it wasn't like you get vaccinated and 2 days later you lose your pregnancy. There was a delay and it was sort of smoothed out over time. And so both of those happening, it was a very easy signal to miss.
Well, I'm certainly glad that most women weren't vaccinated during their pregnancies.
Well, a lot of women got vaccinated during their pregnancy. They got vaccinated later in pregnancy. Now, we're not seeing an increase over the expected number of fetal losses among women vaccinated later. However, we are not looking at what happens after pregnancy. After the baby's born, we're not looking at any kind of fetal anomalies or any other problems that might have occurred in pregnancy. All we're looking at is whether they lost the pregnancy or not. That's it. So there may be other complications involved with vaccination later in pregnancy, but our study doesn't examine those.
What areas of further investigation would you like to do on this?
Well, some of the things that I just mentioned would be worthwhile. Fetal anomalies, premature births, health problems that the newborn babies might experience, those would all be worthy of following up on. I think, again, also looking at this with other data in other countries would be really useful, because it would, first of all, give it, you want to try to validate results as much as possible. An astounding result, and it does fly in the face of existing research, of which there's quite a bit, but I outlined earlier some of the reasons why we think that other studies missed it. But nevertheless, it would still be useful to sort of reproduce this study with other data. By the way, let me take this opportunity to thank my co-authors and collaborators, especially Tal Patalon and Sivan Gazit. These are 2 senior researchers. So where does our data come from? It comes from a major health insurance fund in Israel, covering about a quarter of the population, 2.6 million people, roughly representative of the entire population, and 2 senior researchers. The health fund is called the Maccabi Healthcare Services, and 2 senior researchers there, Tal Patalon, Sivan Gazit, arranged access to the data and helped us throughout collaborating on the analysis and the thinking about the project. We have Tracy Beth Hoog, who's now a senior official at the FDA, and she has done great work on looking at non-pharmaceutical interventions during the COVID period and showing sort of that they weren't as useful as most people thought, and in fact may have caused harm. And Joe Freeman is a physician researcher. He published a paper that was a reanalysis of the original Pfizer and Moderna trials showing very high rates of serious adverse events. And finally, Recep Levy at MIT, professor at MIT. He's now on the Advisory Council of Immunization Practices to the CDC. And I almost forgot. Dr. Yaakov Seged. Yaakov is the head of OBGYN services at Maccabi Health Services, a very senior gynecologist, obstetrician. So these are very senior researchers with established track records and publishing excellent research. None of us would put our name to this paper if we didn't stand behind it 100%. We weren't sort of certain that these results were extremely solid and robust. We tried, as every good scientist should, you try to invalidate your results. You try to find an alternative explanation, something that might explain it, and you try that, and you pull the data, you test it, and we couldn't, no matter what we tried, the signal is there. You can't ignore it. There are ways to cover it up. We did find ways that we could do the analysis, if we did the analysis somewhat similar to some of the papers that have been published, we would have not found this signal. You have to be very sensitive and attuned to the timing of vaccination. And you can't just lump in. What most people do is, even if they're sensitive to that, they lump in the first trimester and the second trimester together, and the sort of apparent safety of the vaccination during the second trimester, because there's so many more women getting vaccinated in the second trimester, kind of drowns out the finding from the first trimester. So you have to be attuned to these timing differences. And once you do that, the signal, you can't make the signal go away.
Well, it sounds great. I can't wait to see what other research you actually do in this area.
Thank you. We're trying to get this paper published, right? So currently it's a preprint, meaning it hasn't passed peer review yet, though we've sent it to various colleagues who've had a look at it and given us feedback and stuff like that. So we feel it's very strong, extremely good data. It's very detailed, individual level health data from women's health records, large sample, very solid methodology. So it should be published. It will be published. It's just a matter of time. We have other ideas and plans in the works for the things that we want to look at next. So this took a long time. I want to say it took 20 months. It took 20 months for us to put it up as a preprint. It took a matter of a couple of months for us to find the initial results, but then we tested it, we refined it, we improved, we expanded. There were all kinds of other things that we did. So it overall took 20 months. So it takes time. But yeah, we're not going to give up on this.
It's fantastic. I'd love to have you back on the show to talk about your further research when you advance it again.
Okay, absolutely. I'd be happy to. When we have something to share, I will get in touch.
Well, thank you very much. It's been great to have you on the show, and I hope everybody looks at that paper or at least reads about it.
I have a summary of it written for people who, might not want to dig into a thick, complicated paper. I mean, I think we write the paper in a very clear and easy to understand style, but I have a simpler summary of it on my Substack, researchrebel.substack.com. So I can send you that link to the summary of the paper if you'd like.
Thank you. That's great.
Okay.
Well, thank you for being on the Kiwi Rocket. And I hope that people will take heed of your research. Maybe you can save some lives in the future, or at least give people
I
answers.
hope so.
Them. Yeah.
I heard the Japanese health authorities are no longer recommending COVID vaccinations in pregnant women. That was just announced a couple of days ago. I'd love to think that our research had something to do with that decision. I don't know that it did, but yeah, I think, the tide is turning. At some point, public health authorities are going to have to come to terms with the side effects and the adverse events that the COVID-19 vaccines have caused, the mRNA vaccines have caused. Joe, I don't know, are you familiar with the whole process 1, process 2
Yeah.
difference? Okay, so Recep Levy and I are among the first to have brought it to the public's wider attention, and also showed that So there was this manufacturing process from a clean manufacturing process to a dirty manufacturing process. The Pfizer trial was done using the cleaner manufacturing process. The dirty one that has DNA and endotoxin and whatnot was only tested on 250 people. And the results of that comparison were never made public. They were never done, probably. And so essentially, everybody in the world received, well, everybody in the world who received a Pfizer vaccination received a vaccination on an untested product that was not only untested on humans, it was, as far as we know, untested on animals. So it's shocking. At some point, public health, and then they recommended it to pregnant women. Within weeks, in Israel, they started vaccinating in mid-December. By mid-January, they were recommending it to pregnant women in the second and third trimester. 2 weeks later, they started recommending it to women in all trimesters. They had no data to support it. Pfizer's original trial in Israel, they basically only were giving Pfizer. In Pfizer's original trial, pregnant women were not included. Later, they did a trial on pregnant women. They had 173 women, all of whom were vaccinated essentially like the very end of the second trimester, early third trimester. So only late in pregnancy, which by the way is another motivation for our study, because the only randomized controlled trial done on this was done later in pregnancy, not early pregnancy. I hope that public health officials are going to have to come to terms with what they did. We always protect pregnant women, and pregnancies, it's the most sensitive. Think about all the things you're not allowed to do when you're pregnant. You're not supposed to empty your cat litter. You're not supposed to eat sushi, all these other things. But sure, get injected with an experimental gene therapy product. No problem. In fact, you should do it. In Israel, it was even worse because they had the green pass, which meant that essentially you were kind of shut out of public life if you didn't get vaccinated, unless you had an infection. So even for pregnant women, pregnant women were not exempted this regulation. So yeah, it's shameful. But hopefully the tide is turning.
I hope so too. I saw your piece you did on Augusto Roux and the vaccine trials.
Yes.
Absolutely. It's
Yeah,
absolutely
Gusto.
disgraceful.
Yeah, you should consider having a Gusto on your show. He's amazing. He's pursuing legal action against the trial site and the people that were running the trial in Argentina. I don't know if that's going to go anywhere, but
I feel for the guy. I really do.
yeah. There are many irregularities in the trial. Many irregularities. I think in that my posts on my website, on my Substack, I cover some of them. Been a more thorough one that I participated in that isn't on my Substack, but
Thank you very much for being on the show.
my pleasure, Joe. Thank you.